Announcements. Welcome, everyone. We're so glad that you're here with us this morning on our monthly ABIN webinar. Please remember, if you know of anyone interested in integrated behavioral health, to send out this link to them. We want anybody who is interested to join us. Let me take care of some housekeeping issues. We're going to ask that you mute yourselves. Unless you have a question along the way, please go ahead and unmute or put it in the chat. I'll be monitoring the chat this morning, and we'll be asking Rachel some of those questions. We'll also have some time at the end of today's webinar for questions, so please don't hesitate. I know that we can be an interactive group, so let's show Rachel that we have a lot of questions. I do want to remind you, this is a recorded webinar, so staying on today's webinar, you are giving permission for us to record this. I will now go ahead and introduce Rachel. This is Rachel Andrew. She is the owner of Rachel Andrew Consulting, providing consultation and training on integrated case management. She is a director at a health plan with over 2.7 million members, where she leads a multidisciplinary team, including case management, care transition management, condition management, wellness, coaching, and other population health projects. She is the co-author of the Integrated Case Management Manual, Value-Based Assistance for Complex Medical and Behavioral Health Patients. And I have the book, and I have read it, and it is fantastic. And this is why we brought Rachel in, because we thought this is such great information. We want to share it in our monthly webinar. Her prior experience includes over 25 years of university teaching in behavioral health and education programs, and she speaks nationally on the topic of value-based integrated case management. She has over 10 years experience in community mental health, including as a director of 5 clinics and leading grassroots community projects focused on improving the well-being of the community. She has practiced as a mental health therapist in psychiatric hospitals, schools, and community mental health clinics. Rachel's work in other settings includes insurance case management and utilization management clinical roles. Rachel holds certificates in minority mental health, integrated case management, lean, Synetics creative problem solving, and is a certified case manager and child mental health specialist. So with that introduction, I will turn it over to Rachel, and I can't wait to hear all of this information. Thank you, Rachel.
Okay. Yeah, thank you so much. And I'm going to go ahead and share my screen.
Perfect.
All right, so let me give this a try. I'm a Teams person, a little bit less on the Zoom. So let me know. Can you see my screen now?
Perfect. Wonderful.
All right. Well, thank you, Kim, for that lovely introduction. And I am just delighted to be here to have the opportunity to talk to you about value-based integrated case management. It's something that I'm very passionate about talking about. And today, we're going to kind of go through kind of 3 basic things. So first of all, why value-based integrated case management? Why are Medicaid, Medicare, and commercial health plans using this? Why are facilities, why are providers' offices using this particular model? And then we're going to talk about what exactly it is. So what are the core components, the 8 things that make up value-based integrated case management? And then talk a little bit about what it takes to implement, because this is really a change, moving from a traditional case management into an integrated model. So with that, let's start with why. So the problem. So there is evidence, strong evidence, that supports the strong link between behavioral health conditions and chronic illness. And this is an audience who already gets this. So I'm going to kind of go high level over this. But we know that because of the fragmentation of care, that general medical costs for treating people with both chronic and behavioral health conditions is 2 to 3 times more costly. We also know that those that have, one of the top 5 chronic conditions, asthma, diabetes, COPD, et cetera, and have a co-occurring behavioral health condition are 4 to 5 times more likely to be hospitalized. And the problem with co-occurring conditions such as depression and anxiety is that symptoms like fatigue, loss of energy, and inability to concentrate, directly impact one's cognitive ability to engage in goal-oriented activities. Additionally, symptoms like the inability to feel pleasure or feelings of helplessness and hopelessness impacts the individual's motivation to do the hard work that's necessary to make the behavior changes that you need to do to manage co-occurring conditions, both physical and behavioral health. And then if you add in substance use disorders, they directly impact both cognition and a person's motivation, as well as introduce physiological health effects of the substance itself, which then increases the individual's overall kind of health complexity. We also know that individuals with co-occurring behavioral health conditions tend to have a higher tobacco use, they lack proper exercise, they may have a more poor diet, or reduced treatment adherence. Thus, the presence of a behavioral health condition significantly raises the medical costs for managing chronic conditions. And according to Milliman, who's done a lot of study in this particular area, and in 2018, they published probably their third study on this, that between 19 and 17% of the total healthcare expenses could be eliminated with better integration between medical and behavioral health care. So let's talk a little bit more about the problem in terms of the cost. So let me clear the slide for you. So this is looking at, on the y-axis, the per member per month cost of treating individuals with diabetes. The lighter color, which looks purple to me, but might look blue to you on your computer. The lighter color is diabetes without complications, and the darker color is diabetes with complications. And then we're looking at whether or not it has a co-occurring behavioral health condition. And the data demonstrates that individuals that are diagnosed with diabetes, their total healthcare costs increase when they have a co-occurring behavioral health condition. So for example, if they have a non-severe and persistent mental health illness, like depression or anxiety, costs go up 48%. When it's a severe and persistent mental health condition like schizophrenia, costs go up 76%. And if it's a substance utilization disorder, they saw that cost went up 64%. So addressing co-occurring behavioral health conditions really does matter when we're trying to address the overall cost. Let's talk about the problem of quality. So patients are often not getting the care that they need. There's broad evidence and lots of research that shows that Americans often don't get the care that they need, even though the United States spends more money per person on healthcare than any other nation in the world. Preventative care is underutilized, which results in higher spending on complex and advanced diseases, because too often these patients don't receive evidence-based care, such as drug therapies, or they're not provided the assistance that they need to improve their self-management skills. And this is true if you're looking at insured or the uninsured or the underinsured Americans. And the problems, the care for both of these is also fragmented, that patients often receive care that is maybe unnecessary or even harmful for them, that there's provider variation and lack of adoption in evidence-based care. I work in the insurance industry, and it's why we do utilization management. We see vast variation between providers and the care that they're bringing. And then let's talk about experience. So there's a difference between experience and satisfaction. Experience is finding out if each patient, the care that they should have received, did they actually receive it? So did they have access to care? Did they get timely appointments? Do they have good communication with their providers? Did those things actually happen? When you talk about satisfaction, this is, did the expectations of the patient, were they met in that particular appointment? So experience and satisfaction are two different things. So you can have two individuals who had the same experience, they had the same access to information, the same communication, the same timely appointments, but if their expectations are different, you will see a difference in their satisfaction scores. And we often see that patients talk about they're not having that experience that they want or deserve, that their expectations are different than the experience that they are experiencing. And we see experience variations within a provider, within a practice, and then across different practices across the country. And then let's talk about the problem in terms of outcomes. So case management has always had the problem of what is the return on investment? And with integrated case management, what we have found is real outcomes, whether it be in the insurance industry, which I'll talk about a few of the outcomes we have, whether it be in a provider clinic or a patient center home, we're seeing outcomes. So for us, when we moved into integrated case management, and that was back in 2012 for us, we've had 10 years experience with this, our reach rates went up, our engagement rates went up, our active engagement rates went up, and we saw our staffing, we needed less staff because they were being more productive, and the cost per case went down. So operationally for us, we saw significant improvement, and that improvement has stayed over the past 10 years. We also saw clinical outcomes. We used the PHQ-9 and the GAD-7, the Generalized Anxiety Disorder 7. The PHQ-9, for those of you who don't know, measures depression. So we saw depression symptoms go down. We saw anxiety symptoms go down. Our members were getting their post-discharge follow-up. We looked at medical patient center homes, emergency visits went down, hospitalizations went down, as you can see on the slide. And then you may say, well, all that's good and well, but if the quality isn't there and people aren't happy with it, then you haven't won. We've just completed our fourth NCQA audit and got 100% on every single audit we've had. And the last one was just last month, and we came out with 100% as well. So the quality is still there in the services that we're doing. We have high satisfaction as well. So why integrated case management? It addresses quality, it addresses access, it addresses the problem of cost, and it delivers on the outcomes. So what is it? Well, and I see that Roger's joined us on the call, so we're very fortunate to have him. He's kind of semi-retired now. But when we talk about what is value-based integrated case management, Roger was with Cartesian Solution, was one of the individuals in collaboration with the Case Management Society of America who brought it to America. It's been in Europe for over 25 years, brought to America in 2010 with Cartesian Solutions, and has been studied here for the last 10 years. Roger is also a co-author of both the first and the second edition of the Integrated Case Management Manual. So I'll try not to be nervous with Roger watching me here today. So let's talk a little bit about it. The reason integrated case management came into being was they wanted to look at how can we integrate behavioral health more into the medical and specialty fields. But what became apparent very quickly was it's not just the integration of medical and behavioral health, but you also have to address what we now call the social determinants of health. All those other things that are getting in the way of that member being able to access care and follow their provider's treatment plan. So when we define value-based integrated case management, it is a model that uses a relationship-based interdisciplinary approach to address both the clinical and the non-clinical barriers to health improvement. And there's 8 key components that I want to talk with you about today. The first is this relationship-based versus health problem-based approach. In current case management models, the case manager focuses on the individual's condition and interventions like facilitating care, discharge planning, utilization management activities, all very important. And it's also in value-based integrated case management, we start in a different place. We start by getting to know the individual as a person first, and then identify what are those barriers in the physical, the behavioral health, the social determinants, and the health system areas that lead to poor interactions. There is a lot of research that shows the effectiveness of this relationship-based approach in a variety of fields, including case management. We know that if an individual doesn't have a level of trust and connection with that case manager or with their provider, they're not going to be willing to or actually hear the information that we're sharing or take the actions that are needed to make the changes they're going to need to better manage their condition. In integrated case management, building the relationship with the individual is just as important as the individual understanding their condition and understanding their treatment plan. The second concept is around targeting. Who do we target? So in value-based integrated case management, we target individuals what we call health complexity that have high utilization or functional impairment. So what is health complexity? In a nutshell, health complexity is looking at everything that's getting in the way of a patient being able to access care with a provider, have a good conversation with their provider, and then be able to kind of follow that treatment plan afterwards without having extra support. So individuals with health complexity tend to have multiple diagnoses, tend to have co-occurring behavioral health conditions. They may have high service utilization. They may have personal, social, or financial upheaval. They may have functional impairments. In integrated case management, we're looking for that top 5% that are kind of accounting for over 50% of that healthcare spend, those that have a lot of needs that need help and assistance. So once we've targeted these individuals, we've got to outreach and we've got to engage them in services, right? And that's where the secret sauce is. In integrated case management, we're trying to leverage what we call that individual's engageable moment. So instead of just making outbound calls or trying to reach people through that area, we want to, when they're outreaching to us. So in the insurance industry, we have customer service representatives. In provider clinics, they have office staff. When individuals are calling us or showing up at the office, how do we leverage that engageable moment? Secondly, when they meet, when we engage them, when we have that conversation, when we're leveraging that moment, we want to meet them where they're at. We have an agenda. We want to see improved health outcomes. But for us, it may be they're concerned about a claim didn't pay correctly in the healthcare industry. Wherever it is, you've got to meet people where they're at, and you've got to deliver value in each and every interaction as measured by that patient or that client or that member, whatever you call your audience. And so to do that, in value-based integrated case management, kind of the third component is what we call an engagement team. So these are the individuals that we use in our program that make outreach calls to the individual. And this allows the complex case managers to focus in on delivering and doing the work they need to remove those barriers for their individuals and not spending their time trying to make outbound calls. And our engagement team, you know, we're not 100%. Every time we call somebody, they may have, you know, on paper or in our data system, they may look like they're complex, but they may have a lot of resources and may not need our services, or they may need just a few little things. So our engagement team provides those kind of short-term interventions for folks who may not need complex case management. And what's been really key to us with our engagement team is you want to pick clinicians, and whether it be a clinician or whether it be someone who's kind of maybe not licensed. So well, I wouldn't say LPNs aren't licensed, but maybe not a registered nurse, but maybe an LPN, or maybe somebody with a bachelor's level with behavioral health or social work, is that you need folks who have good clinical background, who are very good at assessing quickly, and thirdly, are very good at saying hello and engaging folks. So if you've read the Strength Finder books, they have a category called woos. Woos are really good on your engagement team. And those are folks that we tend to hire to really say hello and engage people to see the value in participating in our programs and case management. So some other examples of engagement strategies that we've put into place are when members are calling into customer service. If it's somebody that we are targeting in our case management program, we flag them. So a little box comes up on our customer service screen, and they can move that box anywhere, but they can't make it small and they can't get rid of it until they answer some questions. So they meet the member where they're at, whatever questions they have, and then they talk about our program. And for those individuals that are interested, they warm transfer them right over to the engagement team, and we start to engage them in our services. Again, leveraging that engageable moment. We also found that we needed to extend our hours. You know, it's great to work 8 to 5. A lot of people like that, but we have folks in a commercial population, they're working 8 to 5. They can't talk to us. So we need people working in the evenings. We have people working on the weekends. And then we also have folks that are working off shifts. They may work evenings, they may work graveyard shifts, etc. So we also have access to case manager 24/7 through our on-call process. And then one of the other things that has been really key to us in engaging members in our services and our program and sustaining that engagement over time is in training them on evidence-based engagement skills. So we went out and we took 2 of our staff and sent them to the motivational interviewing national trainers and got them certified. So they're 2 of like 2,500 in the world that have gone through this particular training program. And they provide very targeted and extensive initial and ongoing training in motivational interviewing. And again, when we talk about training, we talk about skill training. So this is role plays. This is getting feedback. We do call assessments on all of our staff, and we do individualized coaching so that, first of all, we want to get our staff practicing at that highest level of engagement and motivational interviewing skills. And then in order to maintain that, they're in ongoing training and ongoing assessment and ongoing practices groups. Because I figure if the developers of this program still need practice and training, my staff do as well. And it's something that our staff have really embraced. So they bring, when they've had a call that they don't think went well, they get that to one of our trainers and say, hey, listen to this call, provide me some feedback, let's talk through it. And then the other thing that we did to really help our case managers and with engagement was we developed a tool that provides a comprehensive view of the member on one screen for them. And at the top is kind of a summary guide. So for example, we in the insurance industry, we have lots of data because claims come in, right? So on this guide at the top, we can see, does this person have a lot of medication? They may have, let's say they have 20 medications and they have 10 providers and they might have 8 care gaps. And then for emergency rooms, we may see that as green because we color code everything here because we like to make it simple, but they don't have avoidable ER. They're not using the ER. So when we talk to that member and you have those first few minutes or sometimes it's only seconds to engage that person and show your value, we talk about what's it like to manage all those medications, or how are you having any issues accessing care? We don't talk to them about ER because they don't have issues. So this tool really helps guide that conversation. And our case managers are trained to really listen to where the person is at and match them and move forward that conversation. The next component is the single point of contact. So in value-based integrated case management, we don't have behavioral health case managers, we don't have social workers, and then registered nurses. We have one case manager that is managing the physical health, the behavioral health, and the social determinant health, making it really simple and easy for that individual to access the care that they need and to get the help that they need. It's the case manager's job, and we'll talk more about this in a moment, to identify those barriers for that member. And then to support our case managers, what we've done is we've developed a multidisciplinary enterprise-wide support for them. So we have over 25 different departments that have a designated person that my case manager can reach out to in real time. And like I said, we use Teams. They do a chat. We have a channel that's built. They get their question out there. They can get a customer service rep onto a call with them in real time. They can send questions and problems. And so the experts in our company can manage those problems, but the information comes back to the case manager and then they share that with the member, regardless of what that question might be. The next component is really around this whole person assessment, which we're hearing more and more folks talk about. In integrated case management, we start by focusing on that whole person using a narrative. And what I mean by narrative is conversational, relationship-based approach. Again, we start by getting to know the person, not just their condition. So for example, I love to garden, I love to ride my bike, and I love reading mystery novels. I may also have diabetes or a heart condition, etc. I'm not a diabetic, that's not my identity. I am so much more than that. So we start by getting to know the individual as a person. And then we ask them, who's important to them? What are their interests and their hobbies? What are they really passionate about? In other words, what are the things that will motivate this individual to make true behavior changes? Because we're gonna need to be able to leverage that when it comes time to do the hard work of them changing their behavior to better manage their condition. What's gonna motivate them? So we start there, we get to know them as a person. And then next, we focus on identifying and eliminating those individual barriers in the physical health, the behavioral health, the social determinants of health, and the healthcare delivery system. And to do that, our staff are interdisciplinary trained to address that, to have those conversations. So nurses are trained to assess for depression and anxiety using the PHQ-9, the GAD-7. The mental health or the registered dietitians that we have on our team are trained in how to assess those barriers in the physical health. And the reason why this works is because we're not providing care. As case managers, we are facilitating care, we're removing barriers, but we're not treating a wound, we're not providing psychotherapy. So it's assessing, do they have access? The same skills that you need to find access for behavioral health or chiropractic, they are transferable skills across the different domains. Now, this whole person assessment, as I said, is a conversation. We are starting with what is most important to that member. So we ask them about, tell us a little bit about your physical health. What's going on with you? What symptoms do you have? And we're assessing the 6 content areas that you see on this particular slide. But we're not asking members, we're not starting with a list of 150 questions and asking yes and no. We're starting with a conversation. Tell me a little bit about this. And so they start to tell us about their physical health. And then we may say, and how does that impact your emotional health? And we start getting into do they have a mental health? Do they have a co-occurring? Do they have substance use disorder? And we start having those conversations. And when you go to your doctor, do you share this with your doctor, and how's your communication with them? Or when you did share this with your doctor, how did that go? And then they say, oh, well, I didn't share it with my doctor. Tell me more about that. So we have this conversation, and we really let the member, the client, the patient, whatever you call your individual you're working with, guide that conversation. And the case manager then brings in the questions that they need to for the areas that the member may not have naturally gone to. And then we end that discussion with the identification of goals and establishing baseline measures. So we are governed by regulatory, like I said, we have NCQA, we have our federal laws, we have our state laws, we have our own processes and procedures and regulations. That's all behind the scenes. Members don't need to be a part of that we're writing SMART goals, and that we have member actions and provider actions and case manager actions. That's all behind the scenes. When we're having a conversation with the member and they say, I'm really having a hard time, I don't purchase my medications because I can't afford it. We say, is that a problem you'd like us to work on? Yes. Now we've established a goal. On the background, we're doing all of that stuff in our system, but with the member, again, we're meeting them where they're at. We're using the language that resonates with them, and we're making it simple and easy for them to establish those goals. So at the end of this assessment, we have established goals with the member. We understand what those barriers are, and we're going to move them forward. And in case management, in integrated case management, because we spent time getting to know the person, like we know that I like gardening, we can also start to use in our examples and in our language words that are going to resonate with them. So if somebody's interested in gardening, I'm going to talk about seasons, I'm going to talk about growth, I'm talking about life cycles. I'm going to use words that kind of resonate with what's most interested with them. And again, that just helps with the engagement. So once we've done our assessment, we're gathering information to complete what we call the complexity assessment grid. And this is, again, quantifying, where there's opportunity for us to really make a difference and what barriers we should focus in on first. So let me kind of clear the slide for you here. So we have the 4 domains. So biological or physical health, psychological or behavioral health, social determinants of health, and then the healthcare system domains. And then we are looking at 3 different time periods. So historical might be for children or behavioral health their whole life or within the last 5 years. We've got current state, which is typically about the last 30 days. And then vulnerability is really looking forward 6 months out without any help or assistance from the case manager or getting things in place. What is the likelihood that this person's going to have improved health outcomes or kind of fall back into or have more difficulty managing their health? And then you can see, I just want to point, you can see me pointing at all this stuff. Let me see if my arrow works here. You can see within the domains, there are little subsections, right? So let's take, for example, the psychological or behavioral health domain. The first box here is coping with stress. So we're measuring what's their ability to cope with stress and what's their behavioral health history. And so we have a Likert scale that's been developed from 0 to 3. And let me kind of show you what that looks like. And each of the categories has a definition of what it means to score it on that particular scale. And so what we do in our program is we want every case manager to be within a point or 2 of each other. So let me go back to the previous slide. You can see here the score for Lucinda is 34 based on her assessment. So what we're looking for in our case managers is they're at 33, 34, or 35. And the way that we get to that and to get an accurate score that we can use to measure pre and post outcomes of removing barriers is what we call iterator reliability. We give them a case example and we talk through that example with them. So everybody scores the case and then we go through each one of the boxes, the anchor points. And if anybody is off, then we talk through that. We talk through the definitions so that we have a common definition, a common understanding, and how to apply that to each one of the anchor points that's being evaluated. Okay, so then the next thing I want to talk about is member-centric goals. And we hear a lot of people using that particular language. Again, in integrated case management, we're focused on removing those clinical and those non-clinical barriers. And what we're hoping for at the end of their time working with us is that we reverse those barriers. So those barriers are no longer an issue for them, that their health has stabilized, that we're able to return these patients back to standard care, where they have the support system in place, where they can access the care that they need, have good communication with that provider, are following through on that particular treatment plan without the extra help of a case manager. The goal is not for the patients, our members, to become dependent on a case manager. It's the case manager's job to help build that social support network for them, so that, and that professional team for them, so that they can actually get the care that they need. And then we have to move on to the next member, because in my field, I have more people that need our help than I have resources to provide. And I'm sure that's true for many of you as well. And then in terms of interventions, what the case managers are, again, as we go through this assessment process, they're establishing goals and they're prioritizing. And with the integrated case management model, this complexity grid, you can see the prioritization of where there's opportunity. It's the reds or the higher numbers. And that's where we want to prioritize and go first. Again, keeping into account what's most important to the member. So sometimes you have to start with something that's most important to the member that may not be most important to you, so that you earn that trust and that ability to call them back again. Our case managers are not just working in silos. Again, in integrated case management, we're integrating with the provider system, their social networks, their support systems, and bringing all of that together to provide the support that that member needs to move forward. And then because we've trained our folks in engagement skills and advanced communication skills, we've trained them in evidence-based guidelines. We're working with that individual to elicit what they call change talk. And we know that when members start to get into change talk, they are highly likely to follow through on that particular behavior. So we've trained our folks to listen for and how to elicit and how to promote that particular conversation with that particular member to get those things. Okay, and then kind of the last concept I want to talk about is case consultation. So this approach to value-based integrated case managers, and I'm quoting Dr. Cathal, which is assist to target. We know what the barriers are, and we have a plan. The members agree to that, and we're working towards removing those barriers. But not everything works out perfectly, right? So when we're doing this assessment and we've tried some interventions and we're not seeing improvement, or it's going much slower than we anticipated, that's where we need to bring in consultation. And in integrated case management, it's not just talking to a doctor or a person, it's really a multidisciplinary approach. So in my case consultation, I have a psychiatrist, I have a med-surg physician, I have a clinical pharmacist, and they provide expertise in their particular areas to the case managers. But I also have case managers who are actually brand new, who come in from the field and from other practices, and case managers have been with me for 20 years. I've got our managers and myself as the director. We participate and we bring in our experience to that conversation. And then we look outside our department to see, you know, if this is a case where we have a concurrent review, the person's in the hospital, we'll bring the concurrent review nurse or clinician in to that case consultation. And we talk about it. We talk about it. We look at what are the opportunities. And this is a great opportunity to grow and develop not only that individual case manager, but your whole team in understanding situations and complexity and resources and opportunities that are going forward. And it provides that oversight, because as I tell my case managers, we all, you know, I see the world from my perspective. It's based on my life experiences. It's based on my professional experiences, but other folks have different points of view, which can really open my eyes to see things in a different way. And it's in our case consultation, it's really a learning environment, right? Where we say it's a safe place to bring up what you think is, quote, a stupid question, because we don't see them as stupid questions. Because if you're asking it, somebody else has that same question, and we make it very safe for folks. And so our case consultations are pretty robust and people are banging on the door to get time. We also have ad hoc consultations with our medical directors, our clinical pharmacists, our directors. We've built a system where, if a case manager needs help, they have quick access to support to help them so that we're not stopping the work that needs to move forward and our members aren't having to wait because we really want to solve problems in real time. Okay, and with that, the goal, again, we talked about it in why, I'm going to talk about it here in the what, is we want to gather baseline information at when we're first starting with the member so that we can measure outcomes. And so we talk to members about their clinical goals, their functional goals. We're looking at outcome goals in terms of cost. We're looking at their satisfaction of care. We're looking at improved quality of life. We do a pre-test, like as I said, on depression, anxiety. We do social support. We do medication assistance. So we have some outcome measures that we can measure pre and post and show the benefits of our services. Because I don't know about you guys, but I get asked as a director of an insurance case management, what are you doing for me? What is the value that you bring? And what is that financial return on investment? The question never goes away. So with that, I'm going to pause and I'm going to move to implementing value-based integrated case management. So you know why we think it's important. You now got an idea of what it is. So how do you go about moving from traditional into integrated case management? Well, the key to success in implementing this model is managing that paradigm shift from a traditional to an integrated model. It is a major shift for case managers who pride themselves and identify with their specialty case management. They have spent money and time in their education and in their prior clinical experiencing, honing their skills as a registered nurse or in oncology or a high-risk maternity or a social worker. And they take a lot of pride in that, and they should, because they've spent a lot of time and investment in that. And when they move into integrated case management, they have to learn how to manage both the physical and the behavioral health conditions of the individual, which moves them out of their comfort zone, right? It expands their role and it moves individuals onto their caseload that they may feel very uncomfortable working with. So knowing this, it's really important to have a transition plan that, no magic here, it's people, process, and systems to really support this. And for people, you have to have a strong change management strategy in place to move people from where they're at today to see the value and then actually embrace this interdisciplinary approach. I am that person's single point of contact and I can do this. It's important to include staff in this whole process from reviewing the model. So for us, we had designated staff who read Roger's, the first edition of the book, right? Because we were one of the first plans that implemented it. We seek the staff's input, and we actually found that we identified a group of folks to be what we call early adopters, or we call them SMEs, subject matter experts, who could then learn this model and be coaches and also promote the model and see the value with the rest of the team as we brought them along. In terms of functional or structural reorganization, I love this quote: true integration is more than integrating teams. It includes changing the focus of how case managers think about the work that they're doing. And when you think about true integration, like when you're learning a new language, you start with identifying the letters and then the sounds, and then you have small words, but you're not truly fluent in that language until you're thinking in that particular language. And that's the same with integrated case management. You know your staff has arrived when they're thinking and talking in this integrated language. And then in terms of process and systems design, you want all of that automation and to support that integrated thinking. You want it to support that relationship-based approach. You want to also bring in the opportunity for operational efficiencies, as well as being able to gather your pre and your post test so that you can measure the outcomes that you have. And we did a number of things in terms of our redesign that really brought forth this. And if in the Q&A you're interested, I'm happy to talk a little bit more about that with you. And then what were some of the lessons that we learned along the way? Well, in terms of integrated case management, we really focused in on skill building, which means we did the dreaded role play. Because I have to tell you, nurses and behavioral health are a little bit better, but nurses absolutely they hate role plays as a general rule, at least the ones I work with. And so we focused on skill building. We got people in a room and we started practicing together. And what practicing looked like is we would do a scenario. We'd say somebody plays the patient, somebody plays the case manager, and then we just rotated the team into the seat as a case manager. Anytime somebody got stuck, they could ask for help. We had, all the rest of the case management team. We did dyads, we did triads. We did a lot of practice. We had them listen to their calls because our calls are taped and go back through that. And again, focused on skill building, on how do you have that conversation? How do you assess for caregiver needs, right? How do you assess for depression and anxiety? How do you bring that topic up? What's most uncomfortable for you? And then how do we help build your skills in those areas? You need to anticipate that anxiety on the staff is going to be incredibly high. This is out of their comfort zone. And for all of us, when our anxiety gets hard, we sometimes forget what we need to do. It becomes difficult. So to support that, we built in this rapid response to questions. So anytime somebody had a question, we celebrated that they raised their hand, they asked it, and we had staff available every single day. I had a leader who was available just to answer staff questions. And then we had our subject matter experts, our peer supports that were available as well to provide individual coaching in real time so that that case manager could get that question resolved and then move forward with that work. We would gather up all the questions at the end of every week. And then we would do a training. So whatever we got, Friday through Wednesday, whatever the common theme was, we would then do a short training on Thursdays, because Thursday's my day that everybody shows up. That's the one day everybody works on my team. Because we work, we work split shifts. We have people working weekends. So we have, to cover all of the different time zones and stuff. So again, and we were very individualized in our coaching, and that we made it a really safe place to say, I don't really understand this. And we moved the program forward, and we moved their skills forward. And what we found with practice, and very targeted specific feedback, our case managers began to gain confidence. Their skills began and mastery over it. It became less overwhelming to them. Their anxiety reduced. And what we actually found is that our case managers were much more engaged, and job satisfaction. We use the Gallup poll at my organization to measure engagement and satisfaction. And we're one of the highest teams in the whole company. People love this work. Now, did every single case manager that we had prior to this love this? No, we lost some. We lost, I don't know, probably about maybe 20%. They're like, this is not for me. This is not what I want to do. And that was fine. This is not it isn't for everybody, right? It doesn't, not everybody fits into this. So we help them find other jobs. So they may move over to utilization management or to a consulting role or something else within our organization, or they may have left for another case management program that was a better fit for them as well. And so kind of in summary, what we saw is we have a significant opportunity to make healthcare work better by addressing both the medical and behavioral health conditions, and equally, and sometimes even more importantly, those social determinants of health barriers that are getting in the way of our patients, our members, our clients being better manage their conditions. In value-based integrated case management, we really focus in on identifying what those barriers are in those 4 domains: the physical health, the behavioral health, the social determinants of health, and the healthcare delivery system. And that, if you want to implement this model, it's going to take some work, right? You've got to have a strong change management strategy. You've got to also really help case managers and provide the support they need to make this transition. And they can do it. They can do it quickly. They can get it. And when they get there, they're pretty happy with their job. And you can see and demonstrate actual outcomes that make a difference to whoever it is that's asking you for your value on investment or your financial return on investment. And with that, I'm going to stop here and then open it up for questions or comments, or if you don't have any, we'll give you back some time. So Kim, turning it back over to you. Any questions or comments?
Thank you so much, Rachel. Actually, we do. We have a question in the chat, and the question is, how do you all or your care managers collaborate with primary care physicians, primary care physician offices, and especially overcome some of the challenges that are happening with.
Yeah, so it is our standard process to find out who those providers are. And then we make outreach calls to their provider's office. So a lot of times we might be talking with the triage nurse versus the primary care doctor. It depends on the complexity of that particular patient. What we have found is that once we prove our value, not just to the member, but to the provider's office, they start calling us and they start referring individuals to us, and they start asking us for our help and assistance. Because one of the things that we do, and I don't know if you guys are familiar with like Ask Me 3. So we help coach our members in what to ask, how to get the information, and how to share the important information in an appointment with a primary care doctor so that they can be efficient, because we know primary care has, this amount of time per person, right? They just don't have a lot of time to spend. So they find that our folks are not more educated, but they're able to express what they need more efficiently, and they're able to spend more time coaching and talking and providing the care that they need versus, a lot of times some of their patients will talk and talk and talk and take up so much time. Ours are coming in and saying, this is what we need to do. And so we build those good rapports with them. Now, is that 100%? My case manager, we work with people across the whole United States and globally, right? So is it 100%? No. There's some providers who don't have time for us and don't want to do anything. We keep trying, and then we try the office staff, we try the triage nurse, and sometimes we get to the provider, but it is that collaboration. I go out with our provider relations team, and I talk to providers and I say, this is what we do. These are the services that we offer. And from that, we actually have collaborative programs where we have referral processes between the provider and for us. Back and forth, we've built all those systems into place because we've taken the time to build that relationship with them. So we've started with what's the value at the top of the organization. We've started with providers directly, and then we've also started resolving issues for their front office staff and their triage nurses so they see our value. And so that collaboration has moved forward. But it's not 100% perfect. I don't want to say it's 100% because it's not. Sometimes they never call us back. With facilities, we work specifically with the discharge planner. During an inpatient stay, we try to reach them to figure out what those barriers are. We try to reach the member. We try to leverage discharge planners to get ourselves on the discharge plan. And we take work off of theirs. If they're having a hard time, for example, behavioral health treatment is really difficult right now, right? Trying to find access and getting something timely. We take that work off their desk and we start making those calls to find just the right residential treatment facility or the right specialty who has an opening where our member can then get the care that they need, ideally within that 7 days post-discharge. So once they start working with us, they start calling us directly and we get referrals from them as well. The problem is there's a lot of turnover. So you're always reinventing and redoing this work over and over again to address the turnover that we've seen in the healthcare system as well.
I'm sure you're such an important resource. Absolutely. I could imagine that, once the primary care offices realize you're going to be able to help me find a referral for this behavioral health need, or you're going to be able to find a specialty service. Yeah. They're probably calling all the time. Like,
yeah. And what we're filling the gap is between those appointments, there's a lot of stuff that happens that the member needs support and assistance on. They lose their transportation or they can't afford their medications. So they have good intent. And we're the piece that helps bridge that between appointment and appointment to address those barriers. And that's how we frame it to them.
That's fantastic. We had a comment, great presentation. Thank you so much. We had another question, which is, does your team do follow-up with patients after surgery?
Oh, absolutely. So we have a post-discharge follow-up appointment. So we actually like to do pre-admission. So in the insurance industry, so apply this as it will to whatever industry you're in. Sometimes surgeries require prior authorization. I know those are dreaded words in the provider community, right? But that lets us know that somebody's going into the hospital. So we try to reach out with them and their provider and, try to help them understand, like, what's this experience going to be, and start with the post-discharge follow-up even before they go in. When they go into the hospital, if we haven't reached them pre, then we try to reach them or their designee while they're in the facility and the discharge planner to identify what those barriers are to a safe and timely discharge plan. And sometimes it's finding a facility. Sometimes it's helping the family understand that a skilled nursing facility isn't going to feel like, a 5-star hotel. It is what it is, right? And how do we help move people past that? Or maybe they're having difficulty accessing the support they need post-discharge to be able to manage their conditions. And so we can't get them discharged home because there's nothing, they don't have what they need there. So we're working with all of that stuff. And then post-discharge, we're working with the member and their caregiver, and then their outpatient providers as well. So we try to call the outpatient provider prior to discharge once the primary care doctor knows that the person's in the hospital, if they don't, or to the specialty provider. And then we work with them on whatever the barriers are to following that provider's treatment plan focused on readmission prevention, skill building, making sure they have that support team. So sometimes that will be up to like a traditional, like up to 30 days, but sometimes we're working with them for 6 months because the complexity is so great for some of our members that they need help and support, and particularly around the behavioral health post follow-up. It can take a while before they're really established with their treatment team, and they need help and support. And those with substance utilization disorders have a high readmission rate. We're going to follow them even longer to make sure that they're making that progress and they're really established.
Wonderful, wonderful. We're getting lots of good comments. One comment is, will you be able to share your contact information? And so we can definitely get would it be okay if we shared your email in the chat?
Yes.
Best way to
absolutely. Yep, absolutely.
Okay, fantastic. We have another comment / question. As an RN, I find that empowering patients with the skills and confidence to own and self-manage their own health often feels much more rewarding than providing clinical care for the patient. Any thoughts on that or comments on that?
So comments on the rewarding of helping patients do their self-management?
Owning and self-management. It sounds like you talked a lot about that, the importance of the relationship.
Yeah, I would actually agree with that. It's, there's nothing more satisfying than watching people get better and get the skills that they have. So for me, it's training my staff. For my staff, it's watching a member go from where they're at today, overwhelmed, poor health conditions, those types of things, to now being in charge, like being able to articulate with their provider what they need and have those hard conversations, to be a part of the shared decision-making process because we've educated them. We have tools and assistance to help them. And to watch members be able to now not need us anymore. That's the goal of case management, is they don't need us anymore. That's a success, right? Yeah. So there's a lot, again, my staff are really happy with the work that they do. They get a lot of job satisfaction of helping folks with both the clinical and, as you said, the non-clinical barriers that are getting in the way of them being able to do that. And and the beautiful things, the comments that I get on our satisfaction surveys are phenomenal. Our net promoter score is in the 80s, which is just unheard of. People love the work that we do, and our staff, they get a lot of job satisfaction as well. So I don't know if I'm answering that question or not, but absolutely, I'm excited about this work because it feeds my staff souls, and they truly make life-changing differences in people's lives that can sustain over time. Like, we teach them the skills so the next time an issue comes up, they kind of know what to do. And if they don't, we're their single point of contact. They can call us at any time. As long as they're on the plan, they can call us back and we will help walk them through and re-bring them into case management. And we have people who call us back all the time. I need a little help with this, or I need a little tune up over here. And again, we have that relationship. We're that single point of contact. And we have that relationship over years with them. They may not be active in case management for that amount of time, but they can always call back and they just start the conversation right where they left it off.
One of the things that I think is so great about this is, it sounds like you establish the relationship, you meet the needs, and then the patient may not need continued case management. What is your average length of stay in your case management program?
So it kind of depends. 60, 90 days is usually what we can get some folks through the process. Some are 6 months, some are a couple of years. I mean, we have folks that are outliers, But again, the focus is on removing the barriers, and it's action. You know what I mean? We're not calling somebody once a month. We may call them 5 times in one day because we're trying to remove a barrier, right? And we're working with providers, but we're working with them very intensely those first 30, 60 days. And then we're kind of trying to monitor and move things forward. And that's because, and the reason why we're able to move things forward is we're goal oriented, right? We've taken the time, and an assessment takes some time, but we've taken the time to figure out what the root cause is. And that's what we're going to resolve, right? And we're working to resolve that for them. And through our case consultation with our medical directors, our pharmacists, our staff, we're getting that larger view. So things that I might not be able to see, my eyes get open so that I can manage those types of things. And we're getting help and support throughout the whole company to resolve issues in real time. So, 60, 90 days. Again, we have people that we work with for a much longer period of time, but, folks that are going through surgery, post-discharge, those things kind of move a little bit more quickly than maybe somebody who has more chronic conditions, et cetera. So there's some variation.
That's amazing when I think about 60 to 90 days. I was actually looking at reading some research that talked about if we could provide some intentional initial services when there is this acute need, then we'll see patients' issues start to resolve, they start to problem solve, and there's less of a need. And so that's fantastic.
Well, the goal is to get the support system in place, the treatment team in place, so that you don't need the case manager. It isn't about building a dependence. And, some of my case managers, just to be honest, they have people they like talking to. And sometimes we have to say it's time to put them in an active and let them move on. They've got what they need, and we need to move forward as well.
Yeah. So really, for them to establish their support system outside of the case manager.
That's the goal. Yes, the goal isn't to become dependent on the case manager. The case manager's job is to coordinate, facilitate, build up the resources, get them what they need so they can move forward in life. Because again, I've got all these people waiting for the next case manager, right? So I've got to keep the pipeline moving. But if somebody needs to be with us for a year, we've had one person who was with us for this is probably the most complex person we ever worked with. They were with us for 8 years because it was that complex, right? They just had so many health, so many behavioral health, so many issues that, it may be that we're touching base once a month, but it was just the condition, but that's not the norm, right? So we don't have a limit. It's really based on need. And as long as there's goals that need to be addressed, and if something's taking a long time, then that's why we're bringing it to case consult to say, okay, why is this slow? Why aren't we seeing improvement? What do we need to do differently? How do we make this change?
Absolutely. Fantastic. This is amazing material. I know we just have a couple of minutes left. Excuse me. We did have one comment, and I know you touched on utilization management, but just wondered if you could speak a little bit more about how much utilization management is involved in this process.
Okay, so when I speak about utilization management, that's a whole different team. Where I work, the case managers are the member advocates for the member. So they're helping to solve problems that happen with utilization management. So maybe the prior auth, maybe there was a denial, then my folks help with the appeal. So in our department, we see utilization management as a separate specialty. And those folks are doing reviews, going in and out, and we collaborate with them because they're hearing from the provider. Take, for example, inpatient, that there might be barriers to a discharge plan. They're a great referral source over to us to say, hey, this person looked pretty good going in, but now there's all these complications, and they'll refer over to us. Or if there's a difficulty about getting someone discharged, they'll bring a case manager in so that we can help and assist. And we work together, but my case managers don't do utilization management. It's a different skill set, and it's a different mindset. And they're in the advocacy piece. They don't make decisions about the care. And there's some boundary issues around that as well from our perspective. And so we kind of keep those roles separate, but there's a ton of collaboration. The doctor who's doing the review, the clinician that is doing the nurse or the behavioral health specialist that's doing the review, we're working together with the case manager as a team to help move this member forward into better health. So our case managers may be working with the providers on how do you do an appeal? How do you submit in the correct information for a prior authorization. We provide the medical necessity, but my case managers aren't making any of those review decisions. It's separate from, because this is a whole job in and of itself, just trying to figure out all the barriers. And then what we found that when they do both together, it's not that there are models that do that. They tend to end up doing more reviews and less advocacy when push comes to shove and resources get tight. So we've just separated the roles. We used to have them together. We separated them when we went to integrated case management. This is a member advocacy role.
Okay, fantastic. You did a great job explaining that. I know we are at time, so I just want to say thank you so much for your time this morning. I know you live on the West Coast, and so we have to really celebrate and say, yay, Rachel was willing to get up at the crack of dawn to do this presentation with us this morning. And it's phenomenal information. Please reach out to me or Rachel if you have any questions about value-based care case management, and if you want more information. And also you may want to check out the book. I have your book, and it has been a fantastic resource for me. So with that, I know it is 9 and you have to get on to see patients, but thank you for your time, and know we're a resource for you.
All right. Take care. Thanks for the opportunity to share.
Thank you, Rachel. Bye-bye.